cancer prevention. I am here today in my capacity as a consultant and technical advisor working with FIND, and I will be moderating this webinar. As I've said, colleagues, this is a fourth webinar in our series, and we are planning to host a total of seven webinars. So look out for more in the next 3 Thursdays that are coming up in October. We will be hosting the webinars at the same time, 6 to 8 on Thursday. Before we get into more details, let's just clear some housekeeping issues. Firstly, colleagues, the speakers and myself will be able to unmute, but you won't be able to unmute. We will unmute at the end of the presentations when we are handling the Q&A session. Please post your questions in the Q&A session. They will be answered at the end of the presentations. We have 2 presentations today, so we will answer or respond to all questions at the end of both presentations. Also, a reminder, colleagues, to please complete the evaluation form at the end before logging off. It is a very short form, but it really does assist us to know if we are on the right track and if there is anything specific that you would want us to cover. Please also note that all registered participants will receive a link to the recording of the session next week. It will come via email, and it will be coming from our cervical cancer email. Also note, colleagues, that the webinar is accredited for 2 CPD points, which will be directly submitted to the Health Professions Council. There's been questions about attendance certificates. Yes, colleagues, we will issue certificates. Please bear with us as we have a lot of participants, but your certificates will reach you via email. Colleagues, I suppose roundabout now, there are people who are wondering who is FIND. So colleagues, FIND is short for Foundation for Innovative New Diagnostics, and it is a global nonprofit that is focused on advancing diagnostic innovation and improving access to affordable, reliable diagnostic services, especially for women and girls in low and middle income countries at the primary care level and within communities. Another question one would be asking is, why are we so focused on this webinar series? What prompted the series? Colleagues, we know that cervical cancer is a preventable disease, yet it remains the most common cause of cancer in women in Africa, where it accounts for up to 22% of all female cancers. In South Africa, the Foundation for Innovative New Diagnostics, FIND, works with the National Department and provincial departments of health, the private sector, and research institutions to expand cervical cancer diagnostics nationwide. Colleagues, today the focus of the presentation or the presentations is HPV vaccination. We have 2 speakers who are joining us today. The first speaker is Dr. Judith Carter, and the second speaker is Janine Mayer. First up, let me introduce Dr. Carter. She is a specialist obstetrician and gynecologist working in private practice in Johannesburg, here in South Africa. She completed her medical degree at the University of the Witwatersrand in 1997. After internship and community service, Dr. Carter specialized in ONG at the University of the Witwatersrand, obtaining her fellowship in 2003 at the tender age of 29. She obtained her Master of Medicine in the field of ONG in 2005. Her primary focus is gynecology, and she has a special interest in menopausal medicine and gynecological management of the breast cancer survivor. She also has a keen interest in cervical cancer prevention and has established an outpatient colposcopy at the Park Lane Hospital in Johannesburg. Ladies and gentlemen, let me introduce to you Dr. Carter. Dr. Carter, we are honored to have you today. Please take it away. Over to you.
Thank you so much, Dr. Osi. I'm so grateful for such a rousing welcome. Let me share my screen. Fantastic. Okay, so today I'm going to give a rundown on HPV vaccination, how important it is, how it came about. I'm going to give you a little bit on the most recent guidelines and on the South African HPV vaccination program, and a little bit on vaccine advocacy in your own practice on a daily basis. These are my declarations. So this gentleman over here, Dr. Harold Zurhausen, sorry, let me just get out of this. So Dr. Zurhausen was a German virologist who only recently passed away, and he won the Nobel Prize in 2008 for the incredible work that he did that showed that human papillomavirus is the cause of cervical cancer. Years before, he had demonstrated how HPV incorporates its DNA into the host tissue cells and how this progresses over time to the development of cancer. And of course, this is the basis on which the development of the vaccine against human papillomavirus has been based. So we know that well more than 95% of all cervical cancers and 88% of all anal cancers are caused by high-risk HPV subtypes. We also know that 90% of cervical cancers can be prevented by vaccinating young people with the non-valent HPV vaccine. This vaccine can also decrease 50% of HPV-related cancers at other sites. And in addition, there's a significant reduction in the risk of genital warts in women who have been vaccinated, and even in men who are not vaccinated because of herd protection. And this applies to protection from a general cancer point of view, including anal cancers, oropharyngeal cancers as well. There is a degree of herd protection that men enjoy when women, young girls and women are vaccinated. This is one of my favorite slides because this shows what the cancers are that are caused by human papillomavirus and how big the issue is when it comes to cervical cancer. So yes, HPV causes many different kinds of cancer, but of all of them, cervical cancer is the largest number. And of all of these cancers, you can see how women bear the brunt of HPV-related cancer disease. It's a very interesting virus. If you have a look at this timeline of how HPV causes cancer, you will see that the HPV that causes the cancers is often acquired in the late teens and early 20s when girls and women first start with intimate activity, and how the rate of HPV acquisition decreases into the 20s and 30s, but that for a subgroup of women, there's viral persistence and progression. And this leads to precancerous lesions and ultimately with invasion into cancerous lesions in the older women. But it is because of this natural history of HPV infection and the fact that there's a long period of time in which women can have a precancer that makes cervical cancer a completely preventable cancer, either by primary prevention through vaccination or by secondary prevention through screening for cervical precancers and treating those that one may find. So let's look at the incidence of cervical cancer in South Africa. So according to 2020 statistics, almost 6,000 women die of cervical cancer on an annual basis. It is the leading cause of female cancer deaths in South Africa, even more than breast cancer. And if we look at women who are the mothers of our nation, who are the breadwinners, the 15 to 44-year age group, cervical cancer is not only the leading cancer, but also the leading cause of cancer deaths in women in this age group. So a very interesting perspective for anybody who's ever worked in female health. You'll know that there was a trial that came out in 2002 called the WHI trial, where the risk of breast cancer with combined HRT use was purported to be 1.3 times greater than in women who were not on HRT. The risk of lung cancer in smokers is 15 to 30 times greater. But the risk of cervical cancer in HPV 16 positive patients is 710 times greater. This is just a small expression of how important HPV is in the development of cervical cancer. And thank heavens, we have the ability to stop people from getting HPV through vaccination. Why should we vaccinate? Well, a lot of my patients will say, but this is a sexually transmitted disease. How could this possibly have happened to me that I have HPV? Well, this isn't a sexually transmitted disease. This is a sexually acquired infection, and that's very different to it being a sexually transmitted disease. It is almost impossible to avoid. 70 to 90% of the sexually active population will have had an HPV infection at some stage in their lives. It is spread by skin-to-skin contact and by the exchange of intimate bodily fluids. It is not just spread by penetration. And in addition to that, condoms are not fully protective because you don't have to have penetration to exchange bodily fluids or have skin-on-skin contact. The peak prevalence of HPV infections is just after the sexual debut, so it's often going to be in the late teens and 20s. The peak prevalence of the cervical precancers is about 10 years later, and the peak prevalence of the invasive cervical cancer is about 40 to 50 years of age. But bear in mind that in Africa in general and South Africa in particular, sub-Saharan South Africa, our HIV positive rate is very high, and this disease process is accelerated by 10 to 15 years in HIV positive individuals, even those who are well suppressed virally. This is a very interesting study conducted in Tanzania, where they looked at HPV infection in teenagers around the time of sexual debut. And what they found in this study was that 18.5% of young girls who had never had sex were positive for HPV. That is really an astonishing statistic. If we look at South African data at cohorts that have been examined in Soweto and Cape Town, we can see that the prevalence of HPV in general is quite high. And in particular, the prevalence of high-risk cervical cancer-causing HPVs seems to be even higher than the prevalence of low-risk HPV responsible for genital warts. So how does this vaccine work? Well, the vaccine contains virus-like particles, which are derived from the surface components of the HPV virus, specifically a subunit called L1, which is responsible for that viral particle attaching to the host cell and releasing the DNA of the virus into the host cell for integration of that DNA into the host's DNA. So it's a very, very clever virus. But as a matter of fact, no viral DNA is included. So it cannot possibly infect vaccinated individuals. You cannot get HPV from the vaccine. And it is also a very immunogenic vaccine. It produces lots of neutralizing antibodies to the intact virus and much higher immunogenic response than what you would get from a natural infection. And not only that, it also produces cell-mediated immunity. So unfortunately, natural infection with HPV does not confer a significant immune response, meaning that you can get the same subtype of HPV repeatedly throughout your life. Let's have a look at the latest guidelines for who is a candidate for HPV vaccination. And obviously that depends very much on which organization we're talking about and which part of the world we're talking about. So let's start with the WHO. So from their point of view, the primary targets of HPV vaccination programs is going to be girls from 9 to 14 years of age who are pre their sexual debut. Firstly, this age group is less likely to have had any contact with HPV in the past, and that at this age group, the immune response to the vaccine is very robust. So that is why this age group in particular is targeted. Secondary targets are girls who are over 15, boys in general, or men who have sex with men are only targets of this vaccine strategy if it is feasible, affordable, and doesn't remove resources from vaccinating that primary group. So really, we're talking countries that can afford to vaccinate these secondary targets. WHO suggests a 2-dose schedule from 9 years onward in all age groups within the categories, the different vaccines licensed age categories. But off-label, they are also suggesting that single dose in boys and girls from 9 to 20 years of age is a very good alternative and is going to be far easier to make happen in a general environment, because of course it's far easier to give one vaccine to a cohort than it is to expect that cohort to return for subsequent doses. And we've certainly seen there is a fall off that happens between the first and the second dose in programs where there are 2 doses. They suggest that there must be a minimum of 6 months between those shots, but preferably even 12 months. There's no upper limit dosing interval. So in other words, if you have one shot and you need another shot, it doesn't have to be within those 6 to 12 months. You can still get benefit even if it's 3 to 5 years later. When it comes to immunocompromised individuals, they must receive at least 2, if not 3 shots. And there must be a 6-month interval between those first 2 shots. Let's have a look at what the CDC in the US suggests. So for them, they're wanting to vaccinate everyone at 11 to 12 years of age, although one can start at 9. They are suggesting vaccinating all up until 26. And they're only suggesting that select individuals be vaccinated between 27 and 45 years of age. So those are going to be the high-risk individuals, men who have sex with men, immune-compromised individuals, etc. They're suggesting 2 or 3 doses, depending on the age at the initial vaccination. It would only be 2 doses if the vaccination schedule is started before the 15th birthday, or 3 doses if starting over 15 or if immune compromised. And they go so far as to say there isn't even a need to discuss HPV vaccination in most individuals over the age of 27. If we look at the NHS in the UK, what their program is, they're willing to pay for a vaccine for everybody, boys and girls, at 12 to 13 years of age. And they're also willing to vaccinate girls under 25 if they miss the opportunity to vaccinate at 12 to 13. They vaccinate men who have sex with men up to 45 years of age, and they consider vaccinating at-risk transgender individuals, sex workers, and HIV-positive individuals as well. They administer one dose under 25 years of age, and they would offer 2 doses 6 to 24 months apart in 25 to 45-year-olds. And they recommend 3 doses over a 12-month period if the individual is immunocompromised. Let's talk a little bit about South Africa's vaccination program. So the bivalent and quadrivalent vaccines have been registered for use in South Africa since 2008. So we got those vaccines certainly in private practice quite early on. But the South African HPV vaccination program was initiated a few years after that, in April 2014. The vaccine program was a public school-based program that's recently changed, targeting girls in grade 4, because the idea is to make sure that everybody who gets vaccinated in grade 4 is definitely over 9 years of age. The campaigns are run in March and September, and the bivalent HPV vaccine is traditionally what is being provided at a dosing interval of 6 months. In Gauteng in 2024, we're now targeting grade 5s because we want to be sure that we're catching up all those who missed doses during COVID, and they're receiving a single dose of the bivalent vaccine as of now. If we look at our vaccine program and how it has fared between 2014 and 2020, it looked promising. We have more than 80% of girls receiving the first vaccine at the start of the program. That number has steadily declined over the few years prior to COVID. But what is interesting is that coming back for the second dose, there was a significant drop-off, 20% drop-off between the first and the second dose. And unfortunately, that trend has only continued to go down. Coverage has certainly been lower than what was anticipated in early feasibility studies, which had demonstrated uptake rates of well over 90%. And sadly, in certain countries like Rwanda and Seychelles, they seem to have a far better vaccine coverage than we have managed to achieve in South Africa. And COVID-19 certainly has done significant damage to our vaccination program, which we are really trying to get up and started again. So children historically who attended private educational institutions were not included in the national vaccination program, but that has been changed very recently. And those particular individuals had to access the vaccine privately at a very, very great cost, 3 times the price of what it costs the government. And only some medical aids were covering them. And interestingly, there was a survey conducted on social media which suggested that amongst this group of private school children, a single dose was received by less than 20% of this cohort. So we're very grateful that the Department of Health has decided to vaccinate or offer the vaccine to private school children as well. So who can be vaccinated in our country? In our country, the quadrivalent vaccine, which contains HPV subtype 6 and 11, responsible for genital warts, and HPV 16 and 18, responsible for 70% of cervical cancers. This vaccine is registered in South Africa for females from 9 to 45 years, and in males from 9 to 26 years of age. If we look at the nonavalent vaccine or the 9-valent vaccine, not only does it have HPV 6, 11, 16, and 18 in it, but it also has 31, 33, 45, 52, and 58 in it. So it is registered in South Africa for both sexes from 9 years of age onward. We also have the bivalent vaccine, which is what is being used by the health department, registered, I believe, for females from 9 to 27. I stand to be corrected on that. But who should also be vaccinated? So I would argue if there is the ability of an individual to pay for the vaccine themselves, I feel that anybody should have the opportunity to be vaccinated. People who have had sexual activity before should be offered the vaccine. Women who have sex with women are not protected from HPV. They can certainly get HPV, and they can certainly get cervical cancer from HPV. Anybody who currently has evidence of an HPV infection or a precancer, or has previously had this, can still be offered the vaccine. There's some good data out showing that women who have had a treatment of a cervical precancer with a LETS or LEAP procedure seem to have a lower recurrence risk if they are vaccinated at the time of their procedure. And anybody who is going to have a treatment for an HPV-related precancer should be offered the vaccine. I would also argue that anybody embarking on a new sexual relationship or in relationships marred by infidelity should be offered the vaccine. Transgender individuals, victims of sexual assault or abuse. Who must be vaccinated? Well, there's no doubt that immune-compromised people, including people living with HIV, people on immunosuppressants for autoimmune diseases, transplant patients, people with inherited immune deficiencies, should all be offered the vaccine, even though it is not part of a national vaccination program. And then, of course, healthcare professionals who are getting occupational exposure should consider having the vaccine. And it isn't just actually healthcare professionals. For example, in my colposcopy unit, the ladies who are handling the instruments that we use in our colposcopy unit should probably also be vaccinated. Who must not be vaccinated? Well, there really aren't very many of these. People who have ever had an adverse reaction to a previous HPV vaccine should probably not continue with their vaccine schedule. And anybody who is known to have a yeast allergy, because this vaccine is developed in brewer's yeast, or the yeast in particular is called Saccharomyces cerevisiae. And if you have an allergy to that, then obviously you can't use the vaccine. And when it comes to pregnant women, we don't intentionally vaccinate pregnant women. We have no evidence to suggest that there is harm caused by inadvertent vaccination in pregnancy, as it is not a live vaccine, but we still wouldn't intentionally vaccinate women in pregnancy, certainly not at this point when we don't have the data to show that it is safe. So how long does this vaccine last? Well, numerous studies have suggested that it lasts at least 10 years, but it probably lasts even longer than that. Just a little bit on adult vaccination, because I think it is quite topical. There is more and more interest in vaccinating adults, given that the first world has got significantly aging populations, and also the fact that COVID-19 showed us what a huge impact viral disease can have on adults, particularly those with one or more comorbidities. In 2017, the WHO declared a mandate saying that adults should consider being vaccinated against vaccine-preventable diseases to improve morbidity and mortality, as well as improve quality of life. If you look around the world, Italy is considered to have one of the best vaccination programs in Europe, but despite this, the uptake of vaccination, according to the guidelines that Italy has established, is certainly still suboptimal. Why are there issues around vaccinating the adult population? Well, for a couple of reasons. Firstly, healthcare practitioners or people working in the healthcare space don't have knowledge about the benefits of vaccinating adults. There's concerns around whether it's cost effective. Do you get bang for your buck vaccinating an older person? There is a lack of uniformity in recommendations by healthcare providers to patients. And also, Are they going to develop a good immune response? Is this vaccine going to be effective? So we may very well need to look at developing novel vaccines that are better suited to the older population. We also worry about whether vaccines are going to be effective in those who are immune compromised, so those with HIV, autoimmune disorders, or transplant recipients. I would argue these are the ones that specifically need the vaccine. Little bit about immunogenicity. We know that the vaccine is very immunogenic when it's given to younger individuals. There have been studies looking at the immunogenicity of the vaccine in adults between 18 and 45 and 27 and 45, and it has actually been shown to be highly immunogenic with robust and sustained antibody responses even in the older age groups, albeit lower than in the younger individuals. But at the moment, there's no data saying that you need a minimum threshold antibody titer for protection. As long as it's positive, it's protective. Let's talk a little bit more about what are the practical points related to HPV vaccination. And I think this is very, very important for people who are at grassroots level, who are the ones that are giving the vaccine to our population. Always try, if you can, to complete the vaccine schedule with the same vaccine that was used in the past. But sometimes we don't know what that vaccine was, or else it might potentially be out of stock. And if that's the case, then complete the schedule with any available vaccine, or first prize, if the non-available vaccine is available and affordable, that can be used to complete the schedule. If any doses have been missed, you can just resume the vaccination schedule without needing to restart from the beginning. And even though if cost were not a factor and availability was not a factor, the non-available vaccine would be the vaccine of choice. Any vaccine is going to be better than no vaccine. When it comes to revaccinating those who have already been vaccinated, seems to be very little benefit in revaccinating with a non-available vaccine if the person has already had the quadrivalent vaccine. However, there is benefit to be gained from vaccinating with the quadrivalent vaccine if you have had the bivalent vaccine, because of course the quadrivalent vaccine also offers genital wart protection. And in sub-Saharan Africa, where the high rate of HIV positivity means that genital condylomatous disease is a significant problem, there is that added benefit that can come from the vaccines that contain the subtype 6 and 11. When you're looking at immunocompetent individuals between 9 and 14 years of age, 2 doses 6 months apart is considered adequate. And as I said, the WHO and the NHS, they're looking at 1 dose for those individuals. Beware of repeating the second dose sooner than 5 months after the first. If you do that, it means you are going to have to give a 3rd dose. So it's very important that you don't give these doses too soon. Rather make the gap a little bit wider. The minimum interval between the first 2 doses is 4 weeks. And between the second and 3rd doses is 12 weeks. And between the 1st and 3rd doses is 5 months. If any one of those doses is brought forward, you are going to have to repeat the dose in order to get the benefit. So I'd like to talk a little bit about vaccine advocacy and why it is so important. Firstly, what is vaccine advocacy? So this is where we as healthcare practitioners promote the value and the safety of vaccines to individuals and to communities and to any other stakeholders. It's about sharing good quality data in a way that can be easily interpreted. And it's very important that we talk about how vaccination can prevent disease, not just on the individual level, but also on the community level. There's no doubt that this vaccine works, and it's been recommended since 2006. It's considered a key strategy to preventing and controlling cervical cancer, and it is, according to the WHO, one of the vaccines that has the highest per person impact on mortality. That's very important. Think about that. You have got more chance of saving a woman's life by vaccinating her with this vaccine than vaccinating individuals in general with any other vaccine. Vaccinating preteen girls is the most cost-effective public health measure against cervical cancer, and so many doses have been administered, more than 27 million doses. More than 65 countries have got a vaccine program, an HPV vaccination program as part of the immunization schedules. And there have been repeated studies that have shown it to be safe and effective. But despite this, the uptake has been variable. Probably Australia is one of the best places in the world where the national immunization schedule the uptake has been very good. But if you look at a first world country like the United States, their uptake is less than 60%. And a large part of this is because we as healthcare providers aren't promoting the vaccine. And that's partly because we ourselves are a little bit scared of the vaccine. What are we doing to our youngsters by giving this vaccine? And parents rely very strongly on healthcare providers' recommendations and advocacy. So if they're unsure, they'll look to us. And if we don't support the use of the vaccine, they're going to take that information very strongly to heart. So vaccine confidence is the trust that individuals have in recommended vaccines. It's the trust they have in vaccine policies and the health system that delivers the vaccines. And then it is in the healthcare workers who advise people about the vaccines. And that's really the only one where most of us on a daily basis are going to be able to have an impact. So why would parents choose to refuse this vaccine? Well, if you look at this little chart on the right, it differs between girls and boys, and it also differs in terms of where in time you're looking. So if you look, the issues that come to mind are safety, whether it's actually necessary, whether the individuals have got knowledge about this vaccine for their children, whether a physician has recommended it or not, the assumption that their children are not sexually active and therefore do not need it, and whether there is gender necessity. So should boys actually have this vaccine? And one of the things that I think is very important is this assumption that the individuals are not sexually active. So firstly, we want to vaccinate individuals before they become sexually active. But I have had patients of mine tell me that they have been advised by doctors, even gynecologists, not to vaccinate their children until they become sexually active, which is completely incorrect. And I've also heard of patients being discouraged from having the vaccine because they come from very religious, conservative communities where there is this perception that HPV is not going to be an issue for their children. And as I've explained earlier, how ubiquitous HPV is, one does not need to be sexually promiscuous to get HPV and to be at risk of cervical cancer. So healthcare professionals and family members are the ones who often have the most influence on the decision-making around HPV vaccination. What are the common attitudes? Well, I'm not so sure it's safe to be vaccinated. Why should my daughter get it? There's such bad side effects. Are my children going to be infertile if I vaccinate them? Does it mean that my child is going to think she can go and have sex? I never had the vaccine, so why should I give it to my children? Well, this is where we come in to promote HPV vaccine confidence. We often underestimate our influence and we don't take the time to talk about the vaccines, or we ourselves lack vaccine confidence. And that is why it's so important that we also educate ourselves about the safety of this vaccine. It's very important that our role is to show people that there is a high level of risk of this disease. Because if they perceive a high level of risk, they are more likely to vaccinate. So it's important to tell them that this virus cannot be avoided. It's important also that there is not a perception of a high risk to this vaccine, because if they perceive a high risk, they're going to be less likely to vaccinate. So what do we have to do? We have to explain when to vaccinate and why to vaccinate. We have to tell them what the potential side effects are. Don't let them figure it out for themselves after the fact. Because if they get a side effect that they weren't warned about, they're going to tell everybody else, don't have this vaccine. We need to promote the safety of the vaccine. We need to focus on it being a cancer prevention vaccine rather than a vaccine against HPV, which many perceive to be an STD, even though it isn't. And we need to emphasize that it provides long-lasting protection. So how does advocacy look? Well, it can be Instagram posts from UNICEF, for example, and spotlights on what our vaccination programs are in the various countries. But unfortunately, this is what advocates are up against. We're up against public trust in certain countries. We're up against outdated puritanical viewpoints. And we're up against widespread misinformation, which is now easily accessible simply by picking up our phones. So what can you do on a daily basis to advocate for this vaccine? So it's important that you present the risks and the benefits. What are the risks of contracting HPV? What are the benefits of the vaccines? And what are the risks of the vaccines? So just to go through these very important points. Most men and women will be infected with one or more types of HPV at some stage in their lives. You cannot avoid it. And the highest rates of infection are in the young people who are getting all the action, not us old bullets. HPV can cause cervical cancer. And there are many other cancers that it can cause, but cervical cancer is the most important one. And that it's the most common HPV-related disease, and it is an incredibly important cause of female cancer deaths. What are the benefits of the vaccine? Well, it's easy and it's effective way to prevent HPV attributable cancers. It can protect you against up to 90% of HPV cancers. There's been a significant reduction in HPV infection since vaccines were first recommended. Significantly fewer numbers of precancers of the cervix in young women. And this is important because there's nothing worse for a young woman than having to come to a colposcopy unit like I run in Johannesburg for what is a very scary examination, but a very important examination to make sure she's not at risk of cervical cancer. And it provides very long-lasting protection against HPV infection and disease. What are the risks of the vaccines? Of course, it can have side effects. Any medicine, even the Panado you buy from the Shell 24-hour store at the petrol station, can give you side effects. But most people will have absolutely no side effects. The side effects mostly are pain at the injection site. You might find that there is a bit of fever or a headache, nausea, but mostly it's going to be pain at the injection site. And serious reactions are extremely rare. Anaphylaxis, life-threatening anaphylaxis is incredibly rare. Fainting is also pretty common in young teenagers. Who knows what that's about? I think it's got to do with being scared of needles. It's probably unrelated to the components of the vaccine. So my take-home message today is that HPV-related precancers and cancers are common, and they're completely preventable with widespread early vaccination. There are specific targets for the vaccine program in South Africa. It's young girls between 9 and 14, but there is no one that will not derive some degree of benefit from HPV vaccination. It is a safe and effective vaccine. And for most of us, the only power we're ever going to have is in our daily interactions that we have with our patients and their families. We are not going to be able to change policy. We're not going to be able to change guidelines. But we can change patients' perceptions and educate them about the value of this vaccine. So make it count. Promote the vaccine wherever you can, because future generations of women will indeed thank you.
Oh, I was muted. Thank you so much, Dr. Carter, for that. Really, it was a jam-packed presentation. You said it's only 30 minutes, but I knew you were gonna get into it. See what happened now. So,
I'm a passionate speaker. I'm passionate about this topic, and yes, I had a lot to say.
Yes. No, we really appreciate you, Dr. Carter. The questions are coming in the chat, but it's the kinds of questions I would like us to respond to live and not just type the answers. So please leave them alone if you see them. I'm going to read them out for everyone's benefit at the end of Janine's presentation. Thank you so much, Dr. Carter. Hear from you soon.
Pleasure.
Now, colleagues, thank you so much for your attention up to so far. Please do not go away. We are going to respond to the questions at the end of Janine's presentation. Let me, without further ado, introduce Janine Mayer to you. She is our next speaker. She's a social and behavior change specialist and practitioner. She is currently the Social and Behavior Change Manager at UNICEF South Africa, supporting health education and child protection programs. With her UNICEF colleagues, Janine is working closely with the National Department of Health's EPI program team on strategies to reach unvaccinated children and improve the demand for vaccines. Janine has also represented UNICEF on the National Department of Health's Risk Communication and Community Engagement Technical Working Group since 2020, including for the COVID-19, measles, and cholera outbreak responses. Colleagues, Janine started her professional life as a journalist, later specializing in health reporting, and she then moved into development. She obtained her MSc Med by research and dissertation from the Vet School of Public Health in 2012. And colleagues, it is my absolute pleasure and privilege to introduce to you Janine Mayer. Janine, over to you. Thank you so much for joining us today.
Wow. Thank you very much for that very generous introduction. I really appreciate it. And thank you very much for the opportunity to be here this evening and to put forward some of the insights that UNICEF has gained over the past months working on the HPV U-Report poll. Now, this is where the part where I need to check that everyone can see that we are in full screen mode. I'm hoping that's clear. Okay.
Yes, that is clear.
Wonderful, thank you. So what I'm going to speak about this evening is what was actually a global HPV U-Report poll, but I am going to concentrate on the South African data, obviously, because that's what we have time for this evening. To give you a quick overview of where we're going, I'll explain what U-Report is, and then some of the objectives of this poll that was run globally, and then a brief look at all the findings. And some of the key insights that we pulled out from it. Firstly, I want to also at this point pause and say thank you, Dr. Carter. It really was an absolutely riveting and inspiring presentation, and your passion for advocacy was felt, and I really want to echo what you've said in every possible way, and we'll get to some of the data reasons why I'm also saying that. So thank you very much to you. So coming back to key insights, we also have some recommendations on how we might respond to what we've learned here. Bearing in mind, it's not an absolute, it's only one of many, many pieces of work on HPV. And then we have some resources to assist in that response as well. Okay, so heading straight into it. U-Report is UNICEF's bespoke, it's free and anonymous platform that we use to engage young people directly. It is a global platform. As you can see, there's more than 35 million young people on this platform across the world. It's in 101 countries. In South Africa, it's grown very quickly in the last 2 to 3 years. We're now at over 400,000, but we have a way to go, and we are hoping that our current work with DBE will get us a long way down that road. You'll also see with some interest that at the moment, the majority of people on U-Report are male and also slightly older. So that did impact, interestingly, on what our poll results showed. But we have some 37% under the age of 24. How we use U-Report? We use it to deliver our programs, we use it for humanitarian interventions, and we use it for advocacy. So we run a lot of regular polls. Many of you might have seen some of the research or responses on the mental health polls we've run quite regularly. We have chatbots with 24-hour available information to anyone who's signed on onto the platform. The mental health chatbot, for example, today is Global World Mental Health Day. So we know, for example, that 20,000 young people almost have accessed the chatbot on that subject. We also now are using U-Report to link U-Reporters to live chats, which is effectively a case management system. We're looking at child safety and child protection, and also then through DBE looking at some mental health work, but that's coming up next year. The child health work is very much current. And then we use it as well to mobilize young people offline, because as we know, there are limitations and there's a digital divide, and U-Report allows us to, it's a low data platform, and it allows us to kind of mobilize teams offline to promote the online asset, but also the same work offline. So a little bit about the poll. It was a behavioral and social drivers poll. In other words, it followed a theoretical framework for looking at vaccine demand that was developed by a team of global experts and was released really early 2021. So it's been around a while. It basically looks at the 4 main areas or domains of influence on vaccine uptake. And it's a very focused and effective framework. We've used it a lot in many pieces of research and polls. What this particular poll was looking to do was to understand adolescent and young people's awareness of HPV and the vaccine, to identify the key barriers to uptake and the enablers to vaccination, to determine what are the trusted sources from which young people prefer to receive information about HPV vaccines. And then we added another dimension, was to try and explore youth perspectives on their role in influencing government policies. Because there are, as you heard earlier, various different policy positions on HPV and its availability and its rollout. And we are very much at the center of driving youth engagement in any decisions that affect their lives. So we wanted to hear from young people on this issue. Globally, we had a really good response across 22 platforms in 189 countries, and more than 400,000 young people participated. In South Africa, we had over 8,200 responding to the poll when we launched it at the end of May. A really interesting thing was that actually for this poll, 67% of the respondents were female. So given that we understand that, and I have to say upfront at this point that U-Report has limitations. It is not a representative sample. It doesn't represent the entire youth population in South Africa or anywhere. And whatever we get, it's almost convenient sampling of a particular group of young people who are already on the platform. That said, the advantage is that it's very quick and it does give us useful insights which point us in a direction and help us know where we might dig for more information, or use similar kinds of questions for different kinds of methodological approaches like qualitative or nationally representative. Another disadvantage of this particular poll was because it was global, we didn't look at the specific South Africa dimensions like HIV and some of the cross-cutting issues or the intersecting issues, that would be a better word for it, that people would face here. But so you can see the age range there. We had fairly low numbers under 15 and under 19, but telling nonetheless, and there are some insights that I wanted to put out about those. We had a fair number between 25 and 30. And I think the interesting point here is that this age range helps us see both young girls who are immediately eligible for the vaccine, older women who are now becoming eligible now with a shift in government's approach, and also who may be parents and caregivers needing to make a decision about the young girls for whom they are responsible. So the older age group's position is very important as well. We looked at 5 key poll questions. We looked at awareness and social norms. We looked at individual intentions to get vaccinated and what would be motivators and barriers. And then, as I said earlier, the trusted sources and the advocacy issues. Most of the participants were female. Most were under 30. And actually, we had a really large percentage of the response from U-Reporters registered in Gauteng, which aligns really with the way the population is spread across the country. Okay, so part A of this was on basic awareness and peer perceptions and norms. So the first question on, do you know what the HPV virus is? There we have basically a very strong indication that most don't, 66%. There are age variations here, which I'll get to, but a clear indication of really not being clear on what this is. The next question was, there is a vaccine to prevent HPV infection. Has anyone you know received an HPV vaccine? And again, the majority of people said no. And the significance of this question is that if you know someone who has received the vaccine, you're more likely to begin to consider it yourself. It's becoming something that's a little bit more normal within your life. If you don't know anyone, that's something that affects other people. It has no bearing on you. So this figure has age differences. You can see there that actually amongst the under 14s, even though we had a small number of respondents, 33% of them said that they did know somebody who had a vaccine. So clearly the program and people at younger ages, because of the program, are more likely to know somebody. But it is an issue that we can look at how we promote that later on. This question around, do you think most of your close family and friends want you to get the vaccine? This speaks to social acceptability. It speaks to social norms and positive social norms. Again, if we think that's what our family and friends want us to do, we're going to be more likely to do it. So the majority, but not such a large majority, said no. But a good 46% said yes, we can really want to push that one higher, because if we can grow that social norm, that social perception that that's what everybody wants me to do, it's going to be easier then to persuade the individual around their own concerns about the vaccine. Okay, so moving on to individual intention, to motivation, and then the barriers to vaccination. So the question was, there is a vaccine to prevent HPV infection. Would you like to get it? 46% said they would, which is encouraging, but not obviously as high as we would like to see it. I'll go down into the sort of breakdowns on these questions. You can see that 12% said they were already vaccinated, and there was a flat no from 13%, but a good nearly a third of people were vacillating and weren't sure. And actually, when we look at the kind of, as it were, continuum of vaccine uptake, that you have the hardline denial on the one side, and you have the absolute, yes, I want it, on the other side. And then there really is the kind of middle, the people in the middle who are undecided. And that, certainly during COVID, is where we focused a lot of our attention, because it's much easier to shift a large chunk of people who are undecided than a small number who are really hardline and no. So I think that number of being not sure is very important. But when we followed up and we said, okay, why did you get the HPV vaccine? 54% said it was to protect myself. And there's age breakdowns there that we'll get to. So this is slightly deceptive, but it is a significant point. And relating back to what Dr. Carter said, if people can understand the risk of getting infection, and that it is not only via sexual intercourse, then this motivating factor of protection is one that you can really, that's what you'd be pushing even more. So it's a really important one. Doctors' advice is significant. School advice plays a much bigger role in younger age groups than it does obviously in older, but a really, really huge role, 70%. This figure here is 70% for respondents under 14. And then you can see, interestingly, that parents' advice drops and friends' advice drops. So the direct advice is not the influencing here. It's the belief that parents want you to do this. So it's more the social norm than what you're hearing directly from your parents and your friends. So what stops you, sorry, let me go back here. What stopped you from getting the HPV vaccine? Money came up as a factor, no vaccine where I live. So the access issues are often with the EPI program a factor, and that really speaks to how we then tailor the strategies to reach those who are going to be less likely to be able to access the vaccine. I think those are the most important ones there. And then follow up again to that question for the follow up that I wouldn't get the vaccine, we asked, well, why would you not get the vaccine? A strong number are concerned about safety. And this again has a big age range to it that we can go into in a moment. So safety, and then that comes straight back to the role of the health worker in explaining the safety, explaining the benefits, and explaining the really minor risks, not minor, but the minor side effects and the very, very low risks compared to the very high risk of infection. So safety is an issue, distrust of vaccines. And again, as Dr. Carter says, we absolutely know that the rollout of the COVID vaccine shook a lot of confidence around vaccines in general. And we're still trying to get over that hump, as it were. This issue of vaccine, the HPV, is not an issue for me, and that it's a sensitive issue, again, has a big age range to it, insight to it. So we'll come back to that one. And if people said I wasn't sure why I wouldn't get it or I didn't want it, lack of knowledge, which speaks back to the very first question that we asked, is still a big factor, and the safety concerns. The other practical factors, perhaps less so, and the sensitivity, perhaps less so. Okay, so this is another really important slide, given what Dr. Carter was saying again and again. Doctors and health workers are the place that people want to get the information from, the place, the people, the place they will turn to in terms of any health facility, the doctors and health workers in them, and the people. And this is a really strong trend. It is the same across all age groups, and it has held steady right through COVID, and right through any other disease outbreaks. Doctors and health workers are the most influential communicators in this instance, followed by government, and then social media, which, given that this was the same response across all age groups, is a very interesting factor. It tells us where we need to be channeling our resources in communication and in creating the trust in the vaccine. How do we do it? Through these channels. And then we asked a lot of questions around what could young people do regarding governments, to influence governments regarding HPV vaccines. And this was a kind of word cloud. I'll go into a bit of the details shortly. We had a lot of different questions. You can see there were really practical suggestions like home visits and workplace visits. A key theme that came out was young people can help make others aware. This is too small to read, obviously, so we pulled out one or two interesting quotes. This one was saying, we as youth must voice out our concerns because cancer has killed many young people in our country. We must be the one who demand the HPV vaccines if it is not available in our clinics or hospitals. So in a sense, the voice of somebody who now does understand the risk and is concerned and is willing to be very active about it, and showing that there is a resource amongst young people that if we can actually explain the level of risk, we have a team of advocates that could really help drive uptake of the vaccine. And here's another interesting suggestion that really was aligned with the role of young people in helping to communicate around the vaccine, was that youth should be given learnerships by government in regards of popular viruses that impact our lives, so that we encourage in our homes or communities and in schools about vaccination to overcome our people from dying. Well, there is something we could do hand in hand with health workers. So this is not, again, an extensive thematic analysis, but these are really some of the key insights that we have picked up from all those qualitative responses we got to our final questions on advocacy. So I wanted to come back, because I've mentioned it a few times, to the age-related insights. Again, bearing in mind this is a small percentage of the total response, it is nonetheless very interesting, and it might direct us to go and do further research with this particular age group. Firstly, for those, when we asked the question of the vaccine is available, would you get vaccinated? Those who said no, when we probed a bit deeper, it's not an issue for me, was 25%, which is, I think, a full 10% higher than the general. And it is a sensitive issue, again, is 25%. So in other words, for very young adolescents, it doesn't feel like it's a real issue. And it also feels like it's a very sensitive issue, and they might not know how to deal with that level of sensitivity. And I mean, sexual and reproductive health generally is fraught, and this is and HPV is generally associated with that. So you can understand the sensitivities, and you can understand the kind of particular concerns of a young adolescent. And looking a bit further, okay, the levels of knowledge were the lowest amongst young adolescents, not by a significant amount here between this age and the next age group, 15 to 19, but compared to the national at 18, this age group was 14% said they actually know what HPV is. And 20% said they're not sure. So 34% aren't exactly clear what this virus is. And that doesn't help when you think it's not an issue and it's too sensitive for you to even approach. And again, but as I said earlier, many more of them do know somebody who has had the vaccine. So they are more likely to be able to be influenced by what's happening in the world around them, because it's starting to change because of the program. So they know someone who's had the vaccine. So it's not outside their realm of imagination. It's very practical and tangible. But only 40% say they think their family and friends want them to get vaccinated. Again, remember what we saw earlier was that they don't want to hear this from family and friends, but they want to know that their family and friends do believe it's a good thing for them to do. Of those who said they didn't get the vaccine because they were already vaccinated, sorry, go back, 20% were already vaccinated. In other words, that was 20% of the 12 who said they were already vaccinated. But 70% of those 20, 70% of this age group under 14 vaccinated because of school advice. That really highlights the role of what we need to be doing in schools. 20% because of doctors' advice. and 10% because of protecting themselves. So at this age, it is not really, there's a knowledge issue. It's a way of understanding more about why you do need to protect yourself, but also how enormously influential the school environment is on that decision for the child. Okay, we're not here, obviously, at the parent, but if the school advised it and the parent was persuaded, then the child is much more likely to get it, obviously. But looking at just the slightly older age group, wouldn't get vaccinated, it's not an issue for me, a lower percentage than the younger age group. Definitely not a sensitive issue as you get older. Perhaps because, you know, young people are becoming more confident or whatever, we would need to dig further around that one, but the sensitivity is declining. However, the safety issue is then rising. So concerns around safety around older teens then is something we do need to address, because it's become almost, as was pointed out earlier, you know, with what's available on social media and with often amplified voices of a very small number of people, safety has become more of a concern. The knowledge levels are slightly higher at 16%, but still not really at the national level. A lower number of this age group knows somebody who has been vaccinated. And again, about the same, say that they think their family and friends want them to get vaccinated. Those who were already vaccinated, at this age, only 43%, not only, still significant, but a lot lower than the 70% for the younger age groups, said they got vaccinated because of school advice. 13% were because of a doctor's advice, and 29% were on to protect themselves. So it really does point to the kinds of individual concerns of a growing young person as they move through the different age groups, and how we really need to respond to those specifics. I think we'd want to perhaps complement this research with additional qualitative research or maybe more representative research, but it does point us in some very interesting and clear directions. So we thought about some recommendations based on the insights that we've seen here. And one that really stood out was that we need to help young people lead the way on this. We need to build their understanding of what the virus is, what the risks are, and the vaccine itself. But then we also need to build their confidence in their skills to promote it. And this means I understand there are quite a number of government colleagues in the room. It does really, and at school level as well, it's something that needs to be systematic and routine. The involvement isn't a one-off thing in this year and then next year it falls away. It needs to somehow, we need to integrate youth involvement in this particular vaccine. I'm trying just not to say the word campaign, because campaign means it's a once-off. But when we do it twice a year, it's becoming that kind of system that it happens in the first quarter of the year and the third quarter of the year. And we need at both of those times to have systematic youth engagement in that event so that they can help plan and promote. And that includes co-designing and testing the resources that we're going to use to communicate. It also made us think that we need to be creating opportunities and encouraging parents and caregivers, those who did agree to have for their children to get the vaccine. We need to somehow encourage them to explain why they wanted their child to get the HPV vaccine, and to encourage others to do the same. In other words, to actively try and grow a positive social norm. So yes, we need to persuade the parents and caregivers, and I've put in bold here, and I added this as you were talking, Dr. Carter, thank you, around we need to have, as health workers, to really address parents' concerns, but when they make a positive decision, we need to encourage them and give opportunities and help them explain why they're doing this and why it's a good thing and why others should do the same. It's a really important part of helping uptake of the vaccine. I think another look at how we optimize the role of schools in promoting the vaccine, perhaps a bigger role in the community, I'm not sure. I think it's quite a complex issue here, but there really does seem to be an opportunity for schools to play a significant role in preparing young families of young girls for this vaccine as they approach the age at which they will become eligible. This issue of healthcare workers' own concerns and confidence in the vaccine, I think we need to, in a way, face head on. And I say this because when the COVID vaccine was rolled out, the very first group to get that vaccine in February, early February, end of January 2021 were the healthcare workers. And we did a behavioral and social drivers poll for healthcare workers for that vaccine rollout. And we had an astonishing response to a poll. We had 24,000 responses in 1 week. We had 17,000 over 1 weekend, purely because this was the week before the vaccine was rolled out. And it was to healthcare workers who really didn't know much about the vaccine, and their primary concerns were safety and side effects, amongst many others that we can go into another time. But what I'm saying is I think concerns around vaccines were really shaken through COVID. And we need to make sure that everybody, every practitioner is very confident and comfortable with what this vaccine is and the benefits that it brings, knowing the absolute influence, the enormous influential role that they have to play in promoting uptake. Another important point that I think I've made a number of times is that we need to tailor our interventions and our communications for age groups to address the relevant concerns. One that I think I didn't note, but it was on the slide, is that the protecting myself driver of vaccine uptake is really the highest factor as somebody gets older. So in the kind of, I think it was the over 25 and up to 35 age group, that protecting myself was a main driver for getting the vaccine. So that is a very different concern to that of a 9-year-old. And we need to tailor our work accordingly. And perhaps some of the very practical things that we do that don't mean we need to go on national TV, but to give health workers prompt sheets, for example, that have key messages designed for specific age groups and for the specific concerns of the different groups of people that you interact with, could be one very practical and low-cost way of helping to advocate for, promote, and really increase demand for the vaccine. And we know how effective WhatsApp groups are, and it's a really easy thing to send along through a WhatsApp group. UNICEF does have some resources to assist in the design of various communications. We do have a U-Report chatbot on HPV, which we haven't promoted optimally, and we could start doing that through partners, which would give young people really, firstly, it would promote registration on the platform, and it would give them immediate and ongoing access to information like this and to increasingly update it as it happens. We have another website called Internet of Good Things, which is very low data and about to be 0 rated, where we have similar information. We have a basic healthcare workers guide to talking about vaccines, and we also have guides for planning and designing demand creation for HPV vaccination. So these are some of the resources. I know there are significant numbers globally, but it was just a small pointer as to what UNICEF might, in addition, help with. And I'll stop here and over again to you, Madam Chair. Thank you.
Thank you very much, Janine, for that wonderful presentation. I'm not even going to say anything. I'm going straight into questions because I think we have quite a number that we will need to get through. Let me start off with the first one. Someone asked, and I will direct the questions to both of you colleagues. You will hear which one is yours. Someone asked, I see nonavalent vaccine protects one from HPV types that quadrivalent vaccine also protects against. Does it mean if I get nonavalent, I don't need to get quadrivalent? Dr. Carter, can you please break down the vaccines that are available and this terminology so that we are all on the same page?
Okay. So I don't want to mention trade names, let's just talk about what we call the bivalent vaccine. So bivalent meaning two subtypes in it. So that is the vaccine that the health department uses for our children of school-going age. That has got HPV 16 and 18 in it. And that offers you 70% cervical cancer protection. It does not offer any genital wart protection. Okay? Then you have the quadrivalent vaccine. So quad meaning 4. So that offers HPV 16 and 18. Once again, 70% cervical cancer protection. But it also has subtypes 6 and 11 in it, offering genital wart protection as well. Then the nonavalent, or perhaps easier, the 9-valent vaccine has got 9 subtypes in it. It has got 6 and 11 for genital wart protection. It's got 16 and 18, which cause 70% of cervical cancers. And it's got 5 other subtypes in it that cause another 20% of cervical cancers. So the 9-valent vaccine is the best vaccine we have in the world. It's also the most expensive vaccine, but it offers us genital wart protection and 90% cervical cancer protection. So that's the one we would love, but it is very new in our country. We've only had it readily available for about a year, and it is exceedingly expensive. It's about 2,000 Rand a shot, and that excludes the cost of administration. So it is really cost prohibitive at the moment, and we can only hope that with time these prices will drop and that there will be some sort of it's never going to happen on our level, but hopefully from a governmental level, et cetera, they're the ones who have the power to negotiate with those big drug companies that make these vaccines. So you certainly do not have to get the quadrivalent vaccine if you've had the 9-valent vaccine. The 9-valent vaccine covers everything that the other 2 vaccines cover.
Thank you very much, Dr. Carter. A question related to that, I will ask it just so that you will respond to it directly. One colleague is saying, we are having girls who are vaccinated, but they are getting genital warts. Also, are we able to vaccinate at younger age? Yes. Than to isolate this late, which give people questions around sex.
Okay. I think I know what they're getting at. So yes, unfortunately, if you have received the bivalent vaccine, you are not going to have protection against genital wart disease, which is a pity because it is a big problem in our country, particularly amongst HIV positive individuals. And yes, it might not be a cancer, but it can be incredibly debilitating and have a huge impact on quality of life. So, unfortunately, the vaccine that is used most commonly doesn't have genital wart protection. And I think that the remainder of that question is speaking to whether the HPV vaccine can at a point be administered to children younger, when there is no concern around, are we going to be thinking that this youngster wants to have sex or something like that? For example, if we can administer it as part of the really young childhood vaccines, will it take away all of that stigma? And I think that there is data that is starting to emerge on that basis, and hopefully in years to come, there will be, we may very well end up moving the vaccine age younger, but I think there's still a lot of work to be done on that front. I did hear, for example, that infants with laryngeal papillomatosis, so in other warts of their larynx, are getting vaccinated as babies. So, I mean, it's not something completely foreign to us, but I think time will tell how that will evolve.
Thank you very much, Doc. You've just hit two birds with one stone. That question was coming, but you've dealt with it very swiftly. Another question relates to if someone, yes, I'll just read as is. If someone has done a colposcopy, but is already found the virus okay, I think they meant the HPV is identified in the histology. Must they continue to take the vaccine? And also, must we take both types, the one that prevents warts and the one that prevents cervical cancer, or one of these covers all?
So in my presentation, I wanted people to understand that there is really nobody who is not going to benefit from this vaccine. I would say perhaps the patient who already has cervical cancer, really that is too late for her to get the vaccine. But patients who have got CIN3, severe precancers, there is still merit in getting that vaccine. Because if she has had a treatment, a LETS procedure of her cervix for an HPV 16, for argument's sake, potentially you will by removing the precancerous cells, you might get rid of that HPV infection. But the problem is she has got very little natural immunity to that infection. And therefore, she can pick up HPV 16 again, probably from the same partner that she's currently with. Because if one partner's got HPV 16, the other partner might have HPV 16. So we definitely want those patients to be vaccinated.
Thank you very much, Dr. Kat. This question comes up a lot because as GPs, we will pick up patients with precancerous lesions, send them to the gynecologist. The gynecologist does the LETS or whatever ablative treatment, but then when they return them to us, some will say, please do HPV vaccination, or they would have done it themselves. And it has, sometimes caused a bit of friction in terms of understanding why are we doing that. So thank you so much for clarifying that. Another question is, all right, are women over the age of 20 years eligible for HPV vaccine?
Men, boys, girls, men, women, over the age of 9. In our country, we are very privileged. The nonavalent vaccine is licensed for use in men and women, boys and girls over the age of 9. Anybody can have it. The older you are and the more exposure you've had to HPV, the less bang for your buck you are going to get. So therefore, the government is not going to necessarily pay in a low income setting like us to vaccinate an adult. They will rather take that vaccine and give it to the grade 5 because she is the one who is going to derive the most benefit. But in an environment where patients could potentially pay for this vaccine, we mustn't assume that we're not going to talk about it because they will never be able to afford the vaccine. No, they must be told about it. They must be told it's a Schedule 2 medicine. You do not need a script for this vaccine. And that's the other thing that bothers me is that patients will go to Dis-Chem or Clicks and get turned away because they don't have a script. That is terrible. Anybody can get this vaccine.
Thank you, Doc. And another question, even though I think you might have touched on it, but I'm going to ask it anyway. Do you think that the age of vaccination is appropriate in our country where we have a high teen pregnancy rate?
So I think that until we have got the data to say that it is going to be as beneficial or more beneficial to vaccinate younger individuals, this is where our evidence says the age group that we should be vaccinating. And I hear that that is an issue. Teenage pregnancy, it's not just the teenage pregnancy rate. Children are molested, sexually abused. That's where they can get the HPV as well, not just from consensual relations, but from non-consensual relations. So it would be fantastic if this vaccine can be administered to younger individuals, but until we have the data, I think this is the age group that we're going to be looking at.
Thank you, Doc. Are girls attending special schools included in the SA HPV program? Are girls attending special schools included in the SA HPV program? Okay. I think that's more a DOH question, but let me attempt to respond to that, Doc. We had Dr. Bamford with us last week talking about the program in the public sector. So she did touch on the fact that the public schools and the private schools are now are all going to be part of the campaign, and she spoke at large about the mother-daughter campaign. She didn't specifically mention special schools. However, the Department of Health, Gauteng, is currently running communication around HPV vaccination, and they specifically speak about it. And they actually have it on the Gauteng Department of Health WhatsApp group. That's where I saw it. And they said it specifically that this campaign will target the public sector, the private sector, and special schools. So I'm assuming that this is national, but I can certainly confirm that in Gauteng, it is in writing that special schools will be included as well. Another question, nanovalent dose nanovalent does not include type 35. That is common in Africa. What's your views regarding excluding a type or types that are prevalent in Africa?
Yeah, so it is a great disappointment to us that HPV 35 has not been included in the nonavalent vaccine. Once again, Africa does not always get the special attention that it deserves. You know, I think it is, obviously, we would love for it to be included, and I think that is a huge problem from an African point of view. I don't see it changing anytime soon, but yeah, it is a significant issue, and certainly in my colposcopy unit, I see a lot of patients with what is called the HPV, high-risk HPV type B. And those patients who get severe precancers from an HPV type B, one of our research projects will hopefully in the future be subtyping those to see how many of them are 35, and I suspect a lot of them will be.
Oh, thanks for that, Doc. Can a patient who received quadrivalent vaccine be given bivalent on follow-up due to stock shortage and vice versa?
So definitely, whatever you want to always try and finish your course of vaccines with the original vaccine. But at the end of the day, if that vaccine isn't available or you don't know what that initial vaccine was, then you give whatever there is that is available, or if you can, you give the non-availant. But if the only one that is available is the bivalent, then that's what you give, because HPV 16 and 18 are the two HPVs that are most important when it comes to preventing cervical cancer. That having been said, certainly from the producers of the quadrivalent and non-availant vaccine, there should be no stock shortages of those vaccines. I'm not sure about the bivalent vaccine, but I suspect that it's not necessarily a supply issue so much as the logistics, getting it from the drug company, getting it to the child. That is where the stock shortages come about, and that's a pity. That should never happen.
Thank you, Doc. Let's move on to the men or the boys. One question is in relation to cervical cancer. How is the general public benefit when boys or men are vaccinated? And wonderful presentation, by the way, the colleague is saying thank you.
So my colleague Trudy Smith, who's my mentor, likes to say that it's not just HPV that men give women and we bear the burden of that. There's another one, and it's pregnancy. They give it to us and we're the ones who carry it. It's the same thing. So, you know, the thing is, they are the vectors. And not only that, they are at risk of cancer. So, for example, oropharyngeal cancer, anal cancer in men who have sex with men, there certainly is significant cancer risk, nowhere near cervical cancer risk. So by vaccinating boys, you're going to protect them from those cancers, but you are also going to protect the women that they will be intimate with in the future. Because if they don't acquire those high-risk HPVs, they will not pass it on. And there certainly is a herd immunity effect in a well-vaccinated community. If you look at a country like Australia that's been vaccinating boys and girls since 2008, they don't see genital warts anymore. They hardly see the cervical precancers anymore. They've made declarations about eradicating cervical cancer before the end of the decade. And that is how effective this vaccine is if it is administered across a broad base nationally.
Thank you, Doc. Janine, I think we are bringing you on board. We have been quiet. Are there any studies conducted on vaccine uptake among boys in South Africa?
I think the short answer to that is no, it's a big gap. I wouldn't say no completely. I hesitate because I have certainly not done an extensive literature review, but it definitely is a gap and there's room for more on that. I know there has been some work done in Uganda, but yeah, there definitely is a gap around that one that would need to be done.
Thank you, Janine. Another question. Oh, my daughter received Gardasil vaccine at age 13. I would like to ask if it is necessary for her to get the second dose.
So this shift from 2 doses to 1 dose has been a pretty recent shift. Guidance from WHO that I presented was published in 2022. But, you know, the thing is, if you look at countries like the UK, they've changed their program to a single shot. It's still considered off-label, but in their community, they feel very comfortable that a single shot will be adequate. I think we do just need to be a little bit careful in our environment because of HIV in our communities and HIV in the pediatric population, that 1 shot may not be sufficient for those children, and that 2 shots or even 3, if we knew for sure they were HIV positive, would be better. But I think for the vast majority, one shot is probably going to be adequate, as long as we know that that child is immunocompetent.
Oh, absolutely. Thank you, Doc. There's a comment from a colleague from the DOH, Mzondi. Thank you for the presentation. Please note that the drop in HPV vaccination coverages in the year 2020 was that the year 2020 was a transition period from grade 4 to grade 5 girls. A directive was given from NDOH that school health teams should vaccinate the outstanding grade 4 girls or those who were missed before we moved to grade 5 girls. Since we started with grade 5 girls, the numbers improved and we were able to reach more than 80% of the targeted grade 5 girls in Gauteng province. All right.
Fantastic.
Now,
excellent news.
Yes, thank you very much. And that is from Mrs. Maros Mzondi, Gauteng Department of Health, Adolescent, Youth, and ISHP Manager. Thank you, Mrs. Mzondi, for that. We really are inspired to hear that we are moving as a province and hopefully as a country as well. There's also a comment, Dr. Carter, wonderful presentation, colleagues. They say both presenters, wonderful presentation. Will Dr. Carter share the presentation? Okay, let me start first before I put Dr. Carter on the spot. There was also a question on the Q&A of how do we access this valuable presentation. Colleagues, everyone who is online right now will receive early next week a link to this recording. So you will have this, you can listen to it as much as you want to and at your own leisure, fast forward, reverse and all that. But Dr. Carter, if there is a request for your slides, can we share your slides as a PowerPoint?
I'm all about, this is about getting information out to healthcare providers and members of the public, so I will happily share whatever I've got.
Thank you very much, Dr. Carter. There's also a comment, these vaccines are so expensive in the private sector. We need to advocate for cheaper cost at pharmacies, especially for non-medical aid parents who want to purchase the vaccine for their children. Okay.
I agree, but I don't know that the pharmacy, the pharmacy is probably not making a heck of a lot of money off this vaccine. The cost is coming from the drug company, and of course they've got research, R&D costs to cover. Also, the other thing we've got to bear in mind is that with time there's going to be generics. There will definitely be generics coming in the future, and that may very well relieve some of that pressure that the public feels. Like, for example, there are certainly generics of the bivalent vaccine available. So watch the space. Things may change in the not too distant future.
Thank you very much, Doc. There is a question, and perhaps my colleagues from the DOH might be able to assist. Someone is asking, do we have enough stock in our pharmaceutical depot? I don't know if any of the colleagues are available to respond in terms of the stock of the vaccine. But while yes, 2 participants have raised their hands. I think it's the colleagues. Lamia, can you assist to unmute the participants? I can't see whose hand is raised. Let me see. Thabo Mashego. I see something that says allowed to talk. Yes, Thabo, you can unmute. Yes. Awesome. All right. Thabo Mashego, you are unmuted. You were unmuted just now. You can go ahead. If not, then Bongiwe Luyanda, you may unmute. Yes, go ahead, Bongiwe.
Can you please repeat the question, please?
Oh, I was asking I was asking for your input in terms of availability of stock at the pharmaceutical depot, at the government depot of the vaccine.
Yes, we have enough.
Okay. And Bongiwe, is this Gauteng, KZN?
KZN, eThekwini district.
Okay, all right. So the colleague who asked, I'm not sure where they are from, but you can hear in KZN there is enough stock. Thank you very much for that, Bongiwe. Thabo Mashego? Okay, all right. So colleagues, if there is any other question, you are welcome to ask it. I'm just going, I had my own question, so I will go ahead seeing that I have the platform. Dr. Carter, oh, before I do that, Lamia, could you please launch the form, the assessment or the evaluation. Now I'm missing the word, the evaluation form. Colleagues, please complete. It's just a few questions. Please complete the evaluation so that we know where we need to improve. And I see hands are coming up as we do that. Dr. Carter, let me just check with you. You said the vaccine, can give one protection for up to 2 years, up to 10 years, but it could be longer. So will we need to get a booster at some point?
So the data currently does not suggest the need for a booster. That may change as time goes by, but I think the thing that we need to see, if you remember that natural history or what the natural progression of HPV disease, the vaccine covers that peak when women are most likely or individuals are most likely to get HPV disease, and then it kind of falls off a little bit. If the vaccine becomes less efficacious, it's likely to be at a time when people are less likely to acquire new HPVs. Although we do know that there's often a peak in the 50s again, probably because that's when the divorces and the partner passes away and then new partners come along. But by and large, it should cover you for the protection at the time when youngsters are the most likely to get new exposures to HPV. But currently, it's probably even longer than 10 years. It's probably about 15 years already. No need for a booster.
Thank you very much for that, Doc. Jamina, I see your hand is up. You are welcome. You can unmute. Jamina Moke. Yes, you may go ahead, ma'am. Jamina, you are unmuted. All right, I'm not sure. Jamina, when you can talk, please go ahead. But I'm going to take one question while we wait for Jamina. Someone is asking, I picked up some lesion. I developed lesions on the fingers post-vaccination. How does one treat that? Developed some lesions on the fingers.
I don't think we must assume that those lesions are because of the vaccination. Association very seldom means causation. And I think that needs to be looked at as being either something different, or, the types of warts that you get on your fingers are not warts caused by HPV 6 and 11. It's different subtypes. So I don't think, even if those end up being warts, they are not because of the vaccine.
Thank you very much, Doc. The last question, Jemina, if you are available, you can speak. Otherwise, we are going to take the last question and then wrap up. There is a question: what is the difference between HPV screening and cervical cancer screening, in brackets pap smear? Can these two tests be done at the same time? Which one of the two plays a significant role in preventing cancers? I was inclined to say we will cover that next week, but we've got the lady doc here who runs the Cocoscope Clinic. Why not? Go ahead.
So indeed, Dr. Trudy Smith, who's going to be speaking next week, will give you a lot of this information. But we used to talk about pap smears. That's the old-fashioned cervical cytology, and it saved many women's lives back in the day. But unfortunately, cervical cytology is an incredibly subjective investigation. It requires you to take the smear from the right place. Somebody has to prepare it in the lab. Somebody has to look at it in the lab. And that means that in general, the pap smear is only about 60% accurate. The HPV test is a test that is either pretty much yes or no. It's 95% accurate. You either have HPV or you don't have HPV. So the latest South African guidelines on cervical screening, which were published last year, are that there is no need to ask for cytology anymore. Try only to ask for primary HPV testing and from 25 years of age. If that primary HPV test is negative, we do not need cytology. But if you are doing a liquid-based collection, then should it happen that high-risk HPV test, the COBAS test, comes back positive, they can immediately then send it to the cytology lab where they will look at the cells under the microscope. If you have HPV 16 or 18 and arguably also 45, it doesn't matter what the cells look like, you should immediately go for colposcopy. If you have one of the other high-risk subtypes in a younger patient who you know is going to come back to you if you don't treat her immediately, you can leave her alone for a year and see if she will clear that virus, because 70% of women will. But we have to be very clear that they are going to return to us, because if they're not going to return to us, the guidelines are that you should treat all patients with high-risk HPVs. So I think let's leave the rest of it, the nuances, to Dr. Smith next week. So you must all come to that, because that's going to be fantastic.
Absolutely, absolutely. Thank you very much, Dr. Kata. Ooh, someone has squeezed in one question. It will be the very last one. And I think it's a good question to close off. Does this mean that we have to give all our patients the vaccine if they have not received it yet?
I think our role is to let everybody know about the vaccine, particularly people in their teens and 20s. That must always be a question that we bring up. Everybody should at least know about HPV. They must know that HPV is the cause of cervical cancer. They must know that that is why they're coming for cervical screening. That is why women have been coming for pap smears all these years. Even in my practice, the fanciest women in Sandhurst don't know why they are coming for pap smears. It is to prevent cervical cancer, and it is our job to explain to people what the causes of cervical cancer are and how it is prevented. And then they get the option of choosing whether it is something that they would want to have and whether they can afford it.
Thank you very much for that, Dr. Carter. I think this was a very good closing question. Just to sum it up and say, after we've had everything, what's the next best step that we are going to take? Colleagues, thank you very much for your attention. Dr. Carter and Janine Mayer, thank you very much for taking time to prepare these wonderful presentations for us. We always learn a lot from our experts. Colleagues, please note that we are not done yet. This was number 4 of 7. So we still have 3 more webinars coming up. So please do not miss it. As I've already said, we are going to send you a link to these presentations, so do not stress. And if you would like to have the PowerPoint presentation, please send an email, and the email address is the one you are going to get the link from. So do not worry about our email address. It is cervical.cancer, but it will come to you with both the presentations. Colleagues, in closing, I just want to say thank you so much. I understand now more than ever that as a healthcare worker, I have a big role to play in instilling vaccine confidence in my patients and my clients. I now understand, after listening to Janine's presentation, that I matter so much in terms of whether someone is going to take up the vaccine or not. I am hoping, colleagues, that after this presentation, you are also confident to talk to your patients. If they are asking you about adverse reactions, you will be able to tell them that even Panado, I quote Dr. Carter, even Panado has adverse reactions. There is no drug without adverse reactions, but you will be able to talk them through the reactions that they might expect and what that they might encounter, and what to do if they experience those reactions. Colleagues, I'm happy that we are here and we are all happy with what has happened. And the reason I'm saying we are happy, Dr. Carter, I don't know if you can see the thank yous, Janine. I don't know if you also are viewing the thank yous from the colleagues. We are really appreciative. We have gotten clinical information. We have touched on programmatic information, and the presentation you gave, Janine, really highlighted key issues around behavior change that we need to consider when we are advocating for the vaccine and when we instill confidence in the vaccine for our patients. Colleagues, thank you very much for your attention. See you next week, same time, same place. The link will come to you. Dr. Carter and Janine, thank you so much. Enjoy the rest of the evening.
Thank you so much, Dr. Elsie.
Thank you. Bye, colleagues.
Thanks so much, everyone. Bye.
Bye.